Woman, an in-depth exploration of the world of women today with Sandra Elkin.
Good evening and welcome to Woman. Our topic tonight is mental health care for women. What's right with it and what's wrong with it? My guests are Dr. Ann Seiden. Ann is a psychiatrist practicing in Chicago. She is Director of Research at the Institute for Juvenile Research in Chicago and Assistant Professor and Coordinator of Research Education in Psychiatry at the University of Illinois. Ann is a member of the American Psychiatric Association Task Force on Women. Also with us is Dr. Naomi Weisstein, Professor of Psychology at the State University of New York at Buffalo. Naomi began her career as a clinical psychologist at Harvard and later switched to experimental psychology. Naomi is the author of the widely reprinted paper, Psychology Constructs the Female. She's also a co-founder of the Chicago Women's Liberation Union. Welcome to both of you.
Thank you.
Does the same definition of mental health apply to both men and women?
No. There was a very famous study done in 1970 by Inga Broverman and some collaborators. And what the investigators did was ask clinicians, people involved in mental health, to describe what they thought a normal, healthy male adult was, and then to describe what they thought a normal, healthy female adult was.
And a normal, healthy adult.
Period. And a normal, healthy adult, right. And what they found was that whereas the definition of a normal, healthy male adult matched a normal, healthy adult, period, in independence, ego strength, sense of self-worth, identity, etc., 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 their definition of a normal, healthy adult female sounded like an infant. Dependence, passivity, narcissism, low self-esteem, lots of things which are also part of the definition of mental ill health. But this was what they said. This is how they described normal, healthy adult females. You had something that you said before that was very interesting about this.
Yeah, well, what I thought was that the Broverman study is terribly important because it shows that clinicians have had different norms of mental health for men and women. And in absorbing this kind of data and thinking about it, obviously it's shot through with preconceptions. The question is how, in the long run, we're going to be able to evolve some flexible concepts of mental health that make it possible to, at the same time, allow for the real differences, perhaps, in the needs of women without using those real differences as some kind of excuse for having a totally different concept of what's healthy, desirable, good.
Well, how did this happen? How do you account for this happening anyway?
You mean that there were differences in the
definitions?
Well, I think that in general, psychiatrists and clinicians and people who are involved in the mental health business or trade incorporate the stereotypes of the larger society. And the larger society think that women are childish, dependent, narcissistic, vain, low self-esteem, etc., etc. And psychiatrists and clinicians don't know any better. So that when they think of healthy or adult or normal, they're really thinking of men. And when they have to think of women, all they can think of are the stereotypes that they have been brought up with.
You may be a little bit too hard on clinicians. I think it's a perennial problem for clinicians that clinicians are expected to, on the one hand, have access to some kind of expert knowledge that hopefully would be really helpful, but on the other hand, have to be in communication with the public that they're serving. And I think that we ought to be able to expect that our clinicians would be a little bit more thoughtful, a little bit more critical in reviewing the evidence than the general public. But it's probably utopian to hope clinicians to be too far ahead of the general public, which is what a lot of this discussion is all about, I think.
Let me ask you this, Anne. There are lots of women who are complaining at this point that the clinicians are not responding to the needs that women are expressing now, to say nothing of being ahead. Do you think that's a legitimate complaint?
Well, it's It's certainly true that there are a lot of problems about meeting the mental health needs of women, and it's probably a good idea to talk about some basic statistics just roughly there. In general, in child psychiatry or child guidance clinics, boys are much more likely than girls to be brought in. After age 18, in mental health settings, women are much more likely than men in most outpatient settings to be patients. So there's a big change, and the reasons for that are something that there's a lot of discussion about. One can argue it different ways. One can say, for example, that the fact that there are more men who are alcoholic, that there are more men who enter the criminal justice system than women do, might indicate that the true prevalence of problems that we might consider mental health problems are not that different. But it's certainly true that in the average outpatient mental health setting, there are more women than men, and of course the drug ads, which almost invariably show the patient as a woman and the therapist as a man, reflect that. So that any discussion of mental health needs in general for the adult population very heavily involves the specific mental health needs of women. I'm not quite sure if that answers your question.
Almost, I think. How would you describe the traditional approach that mental health care has taken to women?
Well, let me start, and then Anne can disagree. I think that the traditional approach, and by traditional I don't mean just Freudian or analytic, I mean what's called insight psychotherapy. And let me define that. Insight psychotherapy means that you look inside your head, find out what it is that you're doing that is making you unhappy or is unhealthy, and then you change it. And the way you change it is by acquiring insight into your motivations for doing what it is that you do. Now, I think that this kind of traditional psychotherapy, whether it's Freudian or neo-Freudian or trendy or swinging or Adlerian or Gestalt, or everybody gets into a big bathtub and holds hands for 24 hours and then realizes that they've always had a negative body image or something like that, I think this is the wrong direction. I think that the reason it's the wrong direction, and we can talk about some of this later, is number one, taken as a whole, therapy has never been shown on the average to be an effective way of changing behavior. That doesn't mean that some people don't get helped by therapy, but if you take those who got helped and you take those who maybe have gotten hurt, you come out with an average which says there doesn't seem to be any difference on the whole, on the average. On the other hand, while there are all these studies showing that therapy is a very chancy process at best if you want to change some kind of behavior that you have, the social psychologists have come along and said, look, if you want to change behavior, all you have to do is put a person into some new kind of social situation, and that person's behavior is likely to change, and in certain situations change really drastically. You know, there's scores of studies. I can mention some later on.
So you think that it's been primarily one of having women adjust?
Oh yeah, I think that okay, two things. Number one, if it's never been shown to change, or on the average it's a very ineffective way of changing behavior, the first thing you can say is, look, it's not working. But I think that it's devoted, in any case, to saying, look at what's inside your own head, try and get that straight. And if you've got that straight, then things are going to be cool for you. Things are going to be okay. Whereas for women, we live in a society where things are not okay. No matter what we do, we live in a society which does not like us, does not give us jobs, does not think we're equal to men, thinks we're inferior in every way. And yet these therapists are saying, if you feel bad if you feel feelings of anger or depression or rage, or you feel like crying all the time or not getting out of bed, it's probably because something's wrong with your head.
Well, we're really talking about two possible approaches to problems, and to use sort of a medical example, it seems to me that it's a little bit like if you were living in the middle of a typhoid epidemic, and the basic problem was the water supply. Obviously, we want to do something about the water supply and not just treat the individual victims. At the same time, if you or someone you know is one of those individual victims, and there is something available which can be done to help, then it seems to me that you're asking a lot of the individual woman to forego help, which might be personally helpful, just on the grounds that there is also a problem which we all need to address ourselves to. It may be that the woman herself will be a more effective change agent if she does get some personal help. It seems to me that the more crucial issue maybe is the one that you alluded to earlier about how do you know whether therapy that you're getting is helpful to you, is harmful, or is missing the point. Because I think we both agree that there are circumstances in which it can be enormously helpful and circumstances under which that isn't so.
Yeah.
Well,
yeah.
elaborate on that, because I think that's very important.
Yeah.
Well, that of course is a very complicated issue, but it's one that's been talked about a great deal recently in terms of the women's movement and the criticisms that have come from the women's movement about therapy. And one of the interesting things that happened was that women who were active in the Association for Women in Psychology kept getting requests for referrals to a feminist therapist from women who wanted personal therapy, but at the same time wanted to get it from someone who shared their viewpoints about these issues. So there was a roster of feminist therapists that was compiled. And then the question came up about, so to speak, quality control. How do you decide who should be listed? And they finally decided that that was probably too tough to handle, and they would simply say that the list was a list of therapists who had asked to be listed as feminist therapists. But in Chicago, a group of women psychologists and other therapists and social scientists that were concerned about that began thinking about essentially consumer education for women, for people in general, but particularly women who are getting therapy, particularly with respect to feminist issues. And I think the thing that we felt most strongly was that it's too simple to say that a feminist therapist would provide a kind of therapy that was absolutely reliable and that no prior therapist could possibly do that. Because as it's been said before, if you grow up in a racist society, you're naive if you think that that doesn't affect you. The same thing is true for all of us growing up in a society that makes certain sex role assumptions.
I think, Anne, that it might be very important to define feminist therapy, because it might be a term that a lot of people haven't heard to this point.
Well, again, there's a big debate about is there a distinctive thing that's called feminist therapy, or, title of a recent presentation at the orthopsychiatry meetings was, is it feminist therapy or good psychotherapy? Are psychotherapists who consider themselves feminists trying to develop a totally different kind of therapy, or are they trying to criticize some of the kinds of therapy that have been provided with a view towards helping all therapists provide better therapy and helping all consumers of therapy get better therapy?
I'd like to add a couple of things. We're mainly in agreement. I think that your analogy that if there's a typhoid epidemic, you try and find out what's happening to the water supply at the same time that you try and help the victims is really a lovely analogy. I think that people tend to forget that there's a typhoid epidemic, and that most people, and a lot of women who think that they have problems, think that they're the only typhoid victim around. And they think that they've got typhoid because they did something stupid.
Mm-hmm. Mm-hmm.
I remember a panel that we were on where a woman got up and asked us how women could get rid of an oppression complex. And I thought that that was a key question, because she said, okay, well, maybe women, I think I'm oppressed, but then it's a complex. It's something that I have to change myself. So the first emendation that I would make is that I think too many women think that they're the cause of the typhoid epidemic, that they're the only ones that have it, and that there's nothing at all wrong with the water supply, and the water supply is foul. The second thing that I'd like to amend to what you say about therapy is that the whole concept of therapy is under attack and under scrutiny. I agree with you that people need help, and that a lot of us, most of us, are in a lot of pain. And there's no better definition of the pain than psychic pain. I mean, a lot of women are really depressed, and for good reasons, and they need help. Now,
I'm sorry, Naomi, I thought you were finished. Go ahead.
I just want to finish this thought. Now, the question is, does therapy itself help, or is it something about going to a therapist that might help, which has nothing really to do with the theory that psychologists have made about people, with therapeutic practice itself, with any of that kind of stuff? Is it just simple human contact? I just want to go very quickly through a study where it was one of these studies which asks, is therapy helpful? And they had one group of people going to therapists, and the therapists were doing their, quote, therapeutic procedures, whatever you're supposed to do to make a person really better. Another group was going to the same therapists and just having conversations with them, just talking like you and I are talking now. And they then measured how many people got better in each group. And there was no differences between the groups. So it looks as if maybe simple human contact is what we're talking about. And that when we say therapy, maybe we really should substitute the phrase simple human contact and then ask what kind of human contact will help us alleviate some of the psychic pain that we're in.
So you're both really, in a sense, saying, Anne, you're saying there's a lot that's wrong with it, and you're really saying that therapy is not effective at all for women.
Well, in certain ways. I think therapy is a holding action. I think if you're lucky, if you're in pain, you're a woman, you're lucky, you go to a therapist who is a nice person, who's a human person, who likes you, who doesn't think you're just some other damn hysterical woman, who is interested in your getting better or you're helping solve whatever problem it is. In other words, if you buy yourself a good friend, that helps. But that therapy itself has no magic. It has no special secret. It has no received authority, which gives you any handle on helping people any more than a really good friend. That's what I would say. But you would disagree.
Yeah, I find myself falling back on a medical example. Again, it seems to me that we have a feeling that healers are supposed to do something to the person who is the recipient of the healing. That's our model that comes from contemporary medicine, where somebody prescribes a medication and the person takes it, and maybe in the Middle Ages you went to someone who would give you a magic potion and you would take it. But I think the fact is that in the majority of situations, whether you're talking about physical healing or healing in this area, that it's the person's own physiology, their own processes, which in general accomplish the sort of healing that goes on within the person. And what someone does who tries to assist in that process is to do whatever is necessary, sometimes to stand by while it happens, sometimes to set up conditions which are more favorable, and sometimes when something goes wrong to do something about that. If you break a leg and you go to an orthopedic surgeon, the orthopedic surgeon does not heal the bone, but may know something about kind of cast which would assist in holding the leg in such a position that it can can heal itself. And one could get terribly exercised about orthopedic surgery, and who are these people to think that they're healing broken bones when, after all, one does it oneself. But there is some merit in doing those things which can be done to assist the process. Again, I think the issue is whether, in fact, the assistance is really effective and how you can tell.
Would you discuss for just a few minutes the processes of diagnosis? Perhaps in institutions would be a good place to start. Naomi, I think you had some experience with that.
Right. As a matter of fact, it's the experience which told me I should get out of clinical psychology and go into some other kind of psychology. I was working as an intern in a mental hospital. And the interns were sitting around, were invited to what's called the intake interview. It's not exactly an intake interview. It was after a person is admitted to the mental hospital, and about 15 people are present in a room where the head psychiatrist interviews the patient and finds out what's wrong and makes a preliminary diagnosis. And at the time, I think, and I still do, that this is a terribly brutal way for a patient to be introduced to the institution. That is, the patient has problems, the patient is in pain, the patient is brought into a room where 15 people are watching that patient's most personal problems get displayed. And in this particular session, a woman who was 47 years old, who had been working as a secretary for the past 20 years, Catholic, hadn't finished high school, was brought in. She had had a schizophrenic episode in the office. In other words, she had been hallucinating. She'd seen some giant cockroaches or something classical. She was brought in, and when we saw her in the interview, she was really together. And she kept saying to the psychiatrist who was interviewing her, "Look, I had a little trouble, but I'm okay now." And we learned about this patient's history, and it was really a gruesome history. She had had a hysterectomy 3 years prior to admission on the urging of her boyfriend, who had then run away about 2 weeks before she had this episode. He had just split. He'd left town. And you think, okay, for this kind of woman, for the kind of training that she's had, to have a hysterectomy, to say, I'm not going to have children anymore because of this man, and then to have the man leave, to have her be 47 years old, single, a secretary making no money at all, looking at the rest of her life and saying, what's it going to be like? I think that any of those very, very much more fortunate people in that room watching that woman would have had a much stronger reaction had they been subjected to the same stress. In any case, she really had come back, and she was sitting there, and the psychiatrist was asking her questions that were very difficult for her to answer. And she kept saying, I had a little trouble, and I know I had a little trouble, but I'm okay now. After the interview, the psychiatrist gave his diagnosis. He said that chances for her recovery were really poor because she had a fixation on her father, who had died at the age of 17. And I was so shocked and furious. It was in '62, and it was before any notions of the women's movement had started being talked about. So I didn't exactly know how to formulate my fury. But I thought to myself, this guy doesn't know anything about this woman's life. He loves the Radcliffe women who come in, and the Harvard guys, and the guys he can talk to who had the same training and class background as he did. But when a woman from South Boston comes in with a most horrendous life prospect, all he can say is, she's an incurable schizophrenic and she's going to go off to a state mental hospital. And that's the day I left clinical psychology.
Perhaps if we'd had the women's movement in 1962, you would have been better equipped to take part in the discussion, and you might still be in clinical psychology.
It's possible. It's possible.
I think one of the things that...
And I just wanted to tell you that I think we have about 2 minutes.
Okay. I just want to say that this, the story you tell touches me also. I don't think it's a typical procedure, that in very many institutions there won't be a large public interview like that, so that the patient won't be subjected to the same kind of public display. And in fact, there are other kinds of problems that happen the other way around, that there may be only one person who actually talks with the patient, who then is tremendously subject to the opinion of that particular interviewer. I think that we're dealing with some really tough problems in this area when we say that someone has personal problems that they might want to keep private, but at the same time they're about to get started on what might be a course of treatment that lasts for some time. It matters to them to have it considered what sort of treatment that should be. It might matter to them a great deal to have several opinions. It might have mattered to have yours as well as that psychiatrist, but had that psychiatrist been the only interviewer, there would be no chance for others to comment. I don't think we have easy answers about how to handle these things, and I think it would be a shame if we set it up like I'm supposed to defend current practice, as opposed to someone else raising questions about it. Because I think both of us have a lot of questions about a number of things.
We're really out of time. I want to
Okay.
thank you both for being here. We'll continue this next week. Good night.
Production funding provided by public television stations, the Ford Foundation, and the Corporation for Public Broadcasting.